Hello and good evening, everyone. Thank you so much for joining us. March is very special because it's Colon Cancer Awareness Month, and we all want to be doing our part to reduce the burden of colorectal cancer. So today we have excellent speakers for you, and hopefully we'll cover all aspects of this cancer. Hopefully everybody can see my screen. So I'll start us off. My name is Asma Shaukat. I'm a gastroenterologist. I also do clinical research in colorectal cancer prevention. And I'll be going over the role of screening and other things we can do in our daily lifestyle and dietary habits to hopefully prevent the risk of colon cancer. So let's get started. So I'll go over some of the recent epidemiologic trends that we're seeing in colorectal cancer. We'll address some of the risk factors, some of the things we can do to reduce our risk of colon cancer, and then I'll leave you with some summary points. Colon cancer is a big deal. It is a common cancer, and it is a highly lethal cancer. It's the third most common cancer in both men and women in the US. And we expect nearly 140,000 new cases this year alone. And it's the second most lethal cancer, responsible for almost about 50,000 deaths every year. Every average risk American has about a 4.5% lifetime risk of developing colorectal cancer. So let's look at some recent trends. What you see here on the graph is time on the x-axis, so starting from 1975 up through 2014. And on the y-axis are colorectal cancer cases in individuals, men and women, age 50 and older. And you can see both those curves have a nice downsloping trend, which is excellent. And we think that's the effect of screening, leading to a reduction in colorectal cancer incidence in men and women. However, in the lower part of the screen, you see the same two lines, but this is in men and women between the ages of 20 to 49, so younger individuals. And there you see these two lines are relatively flat, or there's almost an uptick in recent years. And this uptick has been confirmed in other studies also, suggesting that colon cancer is rapidly rising in individuals younger than age 50. And it's going to be one of the leading causes of cancer-related deaths in younger individuals, younger than 50, in about 10 to 15 years. And this is a concerning trend that we want to address and hopefully try to mitigate. So this trend is not just unique to the US, but these are some global patterns of colon cancer incidence in younger individuals. And suffice to say that globally in countries that are highly developed or westernized, there is an increasing trend of colorectal cancer. So this seems to be a global phenomenon. And you can see all the countries in blue, and you can see where the US ranks. But cancer is on the rise. So this is certainly not just a US problem, but even a global problem. Now let's zoom in a little bit on trends in the US. What you see here is again colon cancer cases by age groups in graph A. And the blue arrow indicates the age group younger than age 49. And this is the group that we're concerned about, where the line is either flat or kind of has an uptick towards its end. Whereas in the older age groups, the trend is nicely trending downwards. So this is the trend that we're kind of concerned about. And these cancer cases for individuals younger than age 50 are more likely to be in men. And there's also there was an initial rise in non-Hispanic whites, and now we're seeing an increasing rise in non-Hispanic Blacks. So you can see again in graph B, the black bar shows how much the relative risk has increased in this age group over time. So compared to year 2000, over 20 years, the relative risk is much, much higher in younger age groups compared to the older ones. So this is really the group we need to kind of focus in on. Again, a graph showing incidence of colon cancer by age groups. And again, you can see this group that's now 45 to 49 has a rising incidence in colon cancer. And that's probably what's leading to a big bump of cancers right at age 50 when we start screening individuals. So, these data kind of compelled us to think about lowering the age to start colon cancer screening. And this graph basically shows where the hotspots are at this time for early onset colon cancer. And you can see they're mostly concentrated in the south and southeast. What are the risk factors for this early onset colon cancer? So multiple studies have shown that the risk factors, well, a lot of them are overlapping with cancers we see in older individuals, but we think the major risk factors are obesity, sedentary lifestyle, smoking, alcohol consumption, a diet low in milk and calcium, high in red meat and processed meats, diets low in fiber, fruits and vegetables, high body mass index, and high fasting plasma glucose or diabetes. And these are all what we now lump together and call them metabolic syndrome. So we think, some of the risk factors are leading to an increased risk. And you can see some of the differences between what we see in younger individuals versus older individuals in terms of risk factors, and some difference in the molecular characteristics of the cancers. But the cancers are actually pretty similar in their molecular pathways, but they're just occurring earlier. So what we think is happening is these risk factors that I just described are essentially leading to an altered microbiome, or what we call dysbiosis in the gut. Our gut is the biggest organ system in terms of the microbiome that outnumber us by many, many millions of folds. And some of these risk factors over a long period of time are leading to an inflammatory environment in the gut, which is contributing to this early rise in colon cancer. And the way it's working is that some of these risk factors preferentially lead to proliferation of these bacterial colonies that we know cause inflammation and DNA damage at the lining of the colon, and intake of red meat, processed meats, and having obesity or sedentary lifestyles actually contribute to proliferating these unfavorable bacterial colonies. So based on all this alarming evidence, in 2021, our U.S. Preventive Services Task Force lowered the screening age. So they made a qualified recommendation and gave it a grade B, meaning there's moderate certainty that there's a moderate net benefit, that we should start screening earlier than 50. And the age that they settled upon was age 45. So this is covered by Medicare, and then other payers kind of follow Medicare. So any modality of screening is fine. However, screening should be addressed and started at age 45 for men and women that don't have any symptoms and don't have any family history or other high-risk features for colon cancer. And for individuals that do have a family history or other hereditary cancer syndromes, we would go even earlier. So this is an important reminder to our primary care colleagues to essentially start addressing this as early as patients in their 20s and 30s, and then understand that screening should start at age 45. Other guidelines now agree. American College of Gastroenterology and the Multi-Study Task Force also recommend screening at age 45. So we have coverage for this. Hopefully there should be no out-of-pocket costs for individuals to initiate this screening process. And we want to kind of get as many younger individuals to screening as we possibly can. Screening should also continue until age 75. And then between age 76 to 85, it needs to be an individualized decision based on the patient's health, as well as kind of other comorbidities and their risk and their preferences. And then screening is generally not recommended after the age of 85, with the understanding that if somebody's had earlier screening and they're so far at low risk, then really there is very little, if to no benefit of continuing screening after age 85, and the risk of complications and harms outweighs the benefit achieved. So how are we doing in the US? Well, not so great. So these are data from the 2020 behavior risk factor surveillance system, where they randomly dial a US representative population across the country and ask them if they've been screened by any of those testing modalities that I just showed you. And you can see that across the US, we're not just one single rate. There's a lot of variation by states. Fortunately, in the Northeast, we tend to do better than the rest of the country, and screening rates tend to be low in the South, particularly the Southwest. So there's a lot of improvement to be made. Now, if we were to average kind of this, checkerboard, we'd come up with an overall screening rate of 68% in individuals 50 and older. So that's great, but it also means 1 in 3 individuals that screen eligible is not up to date on screening. Screening rates by race, so whites and African Americans report similar rates, and screening rates are lower in Asians and Hispanics. And then this survey asked individuals that weren't screened major reasons for lack of screening. And 2 things emerged. One was lack of health insurance, and that's understandable. Without access to healthcare, patients don't have great options to undergo screening. But a low-hanging fruit was not having a regular healthcare provider visit. So to me, that's truly our low-hanging fruit, because these are patients that have insurance, they're part of our healthcare systems. They just don't see a physician often enough to really get recommendations for screening. So this is something we can help with outreach. And now we've unleashed another 21 million individuals between the ages of 45 to 49 in the US by lowering the screening age. So we've created, quite a lot of work for ourselves. So this is truly an area of need. So how do we get people screened? Well, fortunately, we have more than one option for colon cancer screening. We have colonoscopy, which is the most widely used screening option in the US. And you can see how sensitive and specific it is for detecting colon cancer. We think it's the most sensitive test, not just for colon cancer, but also for these precancerous lesions. However, it is an invasive test, requires a prep, requires time off, and sedation or anesthesia. So there's risks involved. There's 2 stool tests that are currently available. The FIT, or the fecal immunochemical test, is done yearly and has a lot of great evidence that it reduces risk of colon cancer incidence and mortality. And then the Cologuard, which is the multi-target stool DNA test, is also a stool test available. And if negative, needs to be repeated every 3 years. So those are tests that can be done in the comfort of the patient's home and the sample mailed in. So they're a lot more conducive for busy individuals or those that don't want to sign up for a colonoscopy. How do we pick from these? Well, truly, adherence is key. So the best test is the one that the patient is willing to complete. So if they're willing to complete a colonoscopy, great. Screening colonoscopy is the way to go. But if not, then one of these stool tests is a great option also. And now, just in the last year or so, we have 3 new tests for colon cancer screening that are going to soon be available with our healthcare systems and providers. So there's 2 new stool tests and actually a blood test that was recently approved also. The stool test, one of them is by genioscopy. It's a multi-target stool RNA test. The pivotal study was done in about 9,000 individuals. And you can see the sensitivity for detecting colon cancer is pretty high, as well as the specificity. Cologuard has a new version. It's going to be called Cologuard Pro. And this pivotal study was done in 20,000 individuals, and you can see really high sensitivity for detecting colon cancer. And And then a recently approved blood test. It's called SHIELD. And this test is based on detecting kind of microscopic amounts of tumor DNA that's shed from a growing tumor into the blood and can be detected via blood test. The study was done in about 8,000 individuals, and you can see the sensitivity is a little lower than the stool tests, but the specificity is pretty good. Now, an important thing to point out is none of these tests are very good at detecting precancerous polyps or what we call advanced adenomas. So that's something to keep in mind, which essentially means that these tests need to be repeated more often than we would for colonoscopy. So here I've put together all the options that are soon going to be available, the three in green that we currently use, and the three new ones that are essentially approved by FDA, Medicare, and soon will be available in our healthcare systems. So really, the menu of options has increased. And the idea isn't to, kind of confuse patients or providers. It's actually to offer additional options. So starting with if a colonoscopy is not something the patient is willing to do or is able to do, then maybe starting with a stool test, and then if not, then thinking about a blood test. But again, screening is doing any screening is better than no screening. Because at the moment, when we add these individuals, younger individuals, 45 to 49 in our screening pool, our screening rates are actually pretty low at only 59%. So that means 1 in 2 individuals that screen eligible is currently not up to date on screening. We want to get this rate to 80% and 80% in every community. So how do we get there? So in summary, there's been a rapid rise in these early onset colon cancers such that colon cancer is trending at younger ages. Risk factors are obesity, the metabolic syndrome that I described, and it's related to ultra-processed diets, which cause a dysbiosis in the gut microbiome, leading to a hostile microbiome profile, which starts this cascade of colon cancer development early. Prevention, one of the most effective modalities for prevention is screening. And average risk screening should begin at age 45 for men and women in the US. Screening should be younger for individuals that have a family history of a first-degree relative with colorectal cancer or have other risk factors such as inflammatory bowel disease or any known or suspected hereditary GI cancers. We should all be thinking about changes in our lifestyle to reduce our risk of colon cancer, such as moderating our intake of red meat, avoiding or reducing our intake of ultra-processed foods. Really, the best food sources are whole foods, grains, and vegetables. And physical activity is really important. Smoking cessation for individuals that smoke cigarettes and maintaining a healthy BMI is truly the key to prevention. So with that, I'd like to thank you for your attention.
Okay, thank you everyone for joining us today. I am actually going to concentrate on one aspect of colorectal surgery today and present a little bit of data and some updates on rectal cancer surgery. In the colon cancer world, really, there's not much happening or new in the surgery aspect. We are using robotic surgery now more and more for colon and rectal cancer. But for the rectal cancer, this is about a third of the patients that get diagnosed with colorectal cancer have rectal cancer. But colorectal cancer, as Dr. Shaukat mentioned, it is the third most common cancer in both men and women. About 5% of Americans will develop colorectal cancer during their lifetime. It is a highly curable disease picked up in the early stages, and you heard a beautiful presentation about how to get screened. There is a rising rate in young adults, which is very alarming, and we don't really understand why. And very intrigued into this trend and trying to do our part in NYU in studying this. So we have actually a study. If you ever come here to have surgery or something, you might be asked to give part of your specimen or samples for this type of investigation. When we're looking at rectal cancer, historically, the problem was the disease, once it's removed from the rectum, it comes back to the area. And then, as you can imagine, removing the rectum leaves the patients with significant functional problems. So some of these historic challenges have been resolved, not all of them. There are some remaining challenges, which is essentially the survival and the disease that comes back and spreads to other organs. I'll speak a little bit about our multidisciplinary program and the NYU program later in this talk. So why is it different to colon cancer? The colon in general is located in the abdominal cavity. There's a lot of room to work. It's attached to the back, which is the retroperitoneum, but it's not really surrounded by many organs. So it's very easy for us, the surgeons, to free it up and reconnect pieces together. And as long as you're removing just one segment of the bowel, the function is relatively normal. From the rectal cancer standpoint, as I mentioned, local recurrence has historically been a problem, and also the functional derangement. So when you remove the rectum acts as a reservoir where it holds a certain amount of stool, and then when it distends, and you get a nature, and then nature calls, sorry, and you go to the bathroom and you empty your bowels. If that was to be taken away, that significantly changes the pattern and the frequency of bowel movement. So you have more urgency, you have more frequency, possible incontinence to stool, and clustering of bowel movements. Also, because the rectum lives in the pelvis, where the bladder and the sexual organs are, the surgery for rectal cancer can negatively impact sexual and urinary function. So historically, these are very historic data from the 1980s and 70s. When patients developed rectal cancer, again, this is old time because there was no CAT scan, there was no MRI, there was barely endoscopy. But patients got diagnosed. The most important test at the time was probably a rectal exam, and you feel it with your finger, and you know it's a rectal cancer. And about a third of these patients developed a recurrence, a regrowth in the area after surgery. Um, what we did find out, and I'll mention that a little bit later, is that if you went to a specialist surgeon, and now there's a lot of people who do what I do, colorectal surgeons, that the local recurrences decreased by about to 10 to 20% compared to the general surgeons at that time, which had a local recurrence of 40%. Most of these show up within 2 years. This was a study that was published from Boston that showed up to 50% in disease that was a little bit more advanced. So a big problem at the time. There was a gentleman called Heald, who's a surgeon in the UK, who essentially focused on doing the surgery a little bit better, which is really how we do the surgery today, and showed that in tumors that did not extend to the bone, and as you can see in this picture, there is, the rectum, which is in the middle, and then right behind it is something called the mesorectum, and that's the sort of the surrounding of the rectum. And if this tumor goes close to the margins of the mesorectum, it doesn't go close to the margin of the mesorectum actually, and then you do the surgery well, you can drop the local recurrence from what I just said to you to about 4%. And he can get people reconnected actually pretty low. So that was pretty revolutionary. This was happening in the 1980s. Another gentleman who was a pathologist, who looked at the specimens, looked at this very carefully and said, if this tumor gets very close to the margin, if it gets very close to the margin, 85% of patients who have margin involvement end up having a recurrence, a disease come back, and the patients who don't have positive margin end up having very little recurrence, 3%. And what we also found out at that time that if you had local recurrence, if you had a positive margin, not local recurrence, if you had a positive margin, which is the circumferential margin, which is the mesorectum, that was positive, this negatively impacted survival for rectal cancer. So again, the take away messages is better surgery reduced the local recurrence, and that if we knew that the local margin is involved, is there any way that we can reduce this involvement? And this, over the last few decades, has led to many trials. Some where radiation was given before surgery, again trying to tackle this issue of reducing the likelihood of positive margin at the periphery, to chemo up front, to the paradigm that we all use these days in rectal cancer surgery, and it's the paradigm that we use here in NYU, which is when a patient shows up, you are going to be sent to get an MRI. We get a CT scan of the chest, abdomen, and pelvis, and then you end up having some form of upfront therapy if the tumor is threatening the margin. If the tumor is threatening the margin. Okay. So this is basically what I just said, an MRI to get worked up, and then some form of chemo and or radiation before. The local recurrence rate uh, acceptable nowadays for surgery is about 5%. Um, as a byproduct of the radiation that was, if you recall, given for reducing the local recurrence, is some tumors actually have disappeared. And over the last couple of decades, we've learned that we can watch these and not offer surgery, and that we're successful in about 70% of the time when the tumor disappears. And now, really, we're targeting therapies where we are trying to increase the number of patients where this tumor disappears. We have excellent long-term survival. And again, reminder that radical surgery, where you remove the rectum, is really associated with a lot of detriment to the function. But we can connect people, um, even if the tumor is pretty distant. A lot of the times we can reconnect people. So what do I mean by neoadjuvant therapy? Therapy up front. Historically, you showed up, you had 5 weeks of radiation with some chemotherapy, either a pill or an infusion, which is called 5-FU or Xeloda, and then you waited 6 to 8 weeks and you went to surgery. In 2018, the National Comprehensive Cancer Network included this option for giving chemotherapy before the surgery. So chemotherapy was only given after the surgery in patients who had lymph node involvement or very negative features of the cancer. Now we started to give chemotherapy before the surgery. And what that's resulted in actually is the likelihood of the tumor disappearing is going up to about 40-50%. Historically, it was about 20% with the radiation alone. Now we've pushed it up to about 40-50%. Um, and in patients whose tumor disappears and it stays gone, meaning how do we know that? You remove the rectum and there's no cancer left. This is a very good indication that the patient has a very high chance of cure. Only less than 5% of those patients have any problem later on. So this was a trial that was conducted actually a few years ago, and it was published a couple of years ago, where basically is what I just said. Some patients started off with radiation, then got chemo. Some patients started off with chemo, then got radiation. The end result was um, anywhere from 50%, 40 to 50% of these patients were able to retain the rectum and had a complete response. And that if you waited a little bit longer, you were able to potentially achieve a complete response. And that we are able to do this safely. We're able to do this safely. Now, if you end up in this paradigm, it is extremely important that you continue to follow up very closely with the team that's treating you. At NYU, we do our scopes at the Cancer Center, and you would come in and you'd be asked to do an enema that day, and we look, and in fact, you can look, and we take some videos. There's no sedation, and we keep that close follow-up for 5 years. Initially, it's every 3 to 4 months, and then we extend it out a little bit. So this we call watchful waiting. In the current paradigm that are used these days, it's up to 50%. The unfortunate news is of up to 30%, 1 in 3 people who go down this road eventually end up having to go to surgery because it fails. It regrows in this scar. And who regrows and who doesn't, we don't really know. And we don't have a good way, and there's a lot of research that's going into that. All we do know is if you get placed on this kind of treatment paradigm, you have to come back every 4 months and get an MRI. You have to come back every 4 months and get a flexible sigmoidoscopy, and that picking it up early is crucial because it doesn't really change um, the outcome. Now, there is some data that in patients which tumors regrow, they might have distant disease, and it's very difficult to really understand if they just had a more aggressive tumor from the beginning and why it regrew. So there's a few issues that are not settled in this paradigm, but again, we have many patients who are going down this road, and this is just an example of an MRI. On the left side here, you can see a very large ulcer with something that's growing out of this wall, and then when they got radiation, it just became smooth in chemo. And a scope, doing a flexible sigmoidoscopy in the office will show you something like this, a very smooth scar which indicates that the lesion has disappeared. That white scar here, these like new vessels we call them telangiectasia. Again, these are all good signals that this is gone. And if you start seeing a little bit of growth in that scar, it's concerning for tumor growing back. I'm going to mention a few slides here about volume and training and about and about our growth here at NYU. So this is some historic data from Canada. Again, looking at who does the surgery. So they looked at 680 patients or so, and this surgery was performed by 50 surgeons. Only 5 of them were colorectal trained surgeons. So 10% of those patients had surgery by a colorectal trained surgeon. And what did they find? If you were trained in colorectal, uh, you treated lower tumors, which are more challenging. Low anterior resection is where you connect people back together. And the rate for somebody who's trained as a colorectal surgeon was 60% versus 25 if you were not trained. And if you, an abdominal perineal resection, which you remove the rectum and the anus and you give a patient a permanent colostomy, that rate was 1 in 3 for people who were trained in colorectal surgery versus almost 1 in 2, 50% for people who are not trained. This really affected even disease-free survival. If you look at colorectal surgery trained um, at the top, they had they had much higher recurrence-free with no recurrence than people who were not trained. And then even when you break it down even further, people who are trained in colorectal surgery and did more than 20 surgeries or cancers a year did even better than ones who are trained and did less than 20. So you want to see a colorectal surgeon that's been trained, and you want to go to a center that are treating rectal cancer with frequency. I think that has the biggest impact on the outcome. Um, this is the local recurrence. Again, it's twice as much for people who don't do as much. So this is more than 21 resections, and you have 10%. And for less than 21 resections, you have 20%. And the survival is also similarly affected. And this is the odds ratio, which means you have 2.5 times the risk if you're not trained in colorectal to have a local recurrence, 2.5 times the risk to have a local recurrence. So it's very important, again, when you're picking your team to treat this problem, is to go to a team that does this with frequency and has experience in this. Um, this is another study that came out from Glasgow, and they showed that the patients who were operated on by a general surgeon were 3.5 times more likely to develop a local recurrence than those who were operated on by a colorectal surgeon. This studies on these issues in Europe were a little bit ahead of the United States. So in Sweden, for example, which was one of the first places that these trials came out of, there was a trial, I mean, not a trial, there were centers that were open for colorectal excellence. And essentially what they showed that from the 1980 onwards, they developed these centers. We didn't really develop these centers in the United States, and we don't really have centers, but we have, an attempt to form these centers. But in Sweden, they formed them from about the 1980s, and they showed that their local recurrence went down from 47 to 13%. And again, I take you back to the beginning of the presentation. Local recurrence can, not always, but can reflect the experience of the surgeon, a mesorectum that's intact, and there's no violation of that mesorectum. This also affected the 5 and 10-year survival in Sweden in those centers. Now, in the United States, this was a little bit of a different story. Most resections for rectal cancer in the United States were actually resulting in colostomy up to the early 2000s. If you look at this number, only about less than in the 1980s, almost 30% of patients ended up having reconnection, and even all the way to the 2003, 50% or just less than 50% ended up having a reconnection. So most patients were ending up with a colostomy when they presented with rectal cancer. That's the status of affairs in the United States at the time. This was the same group, and they looked at more than 7,500 proctectomies that were done by many, many surgeons, and 40% of surgeons in the United States only performed abdominal perineal resection, which means they did not connect. They used this as a surrogate for the surgeon's experience. This was actually the data from county level data, and they looked at 21 states, and then they matched it with all these other um, databases, which is SEER, which is cancer outcomes, socioeconomic variables, screening for Medicare, et cetera, et cetera. And then they broke them out into high stoma counties, which means areas that the patients were getting a lot of colostomies versus others. And that was about quarter of the counties they had high stoma. And when you looked at those, they were doing more than 60% of their surgeries where they were not reconnecting. They were not getting an MRI when they were treating the patients. They were less likely to be in a teaching hospital, and they had many less subspecialty surgeons, like I mentioned earlier, colorectal surgeons. So this led really in the United States to the formation of this consortium for surgical treatment of rectal cancer. This was established in 2011, and essentially many papers were put out by this, and they were basically having a call to action, and they showed that up to 20% of the margins in the United States at the time in 2015 were positive. And again, remember, a positive margin, circumferential margin, gives you an 85% or so likelihood of recurrence and a much poorer survival. So there was a problem which led to this program, which we are part of, and we're in the process of getting accredited. It's a very cumbersome issue, but at the same time, it's very good because we have a pathologist, a radiation oncologist, a radiologist, and surgeons and medical oncologists and surgeons that attend um, weekly conference. We present every rectal cancer patient that comes through our door before we initiate any therapy. And as I mentioned, the treatment sometimes is complicated. Sometimes we start with chemo, sometimes we start with radiation, sometimes we just offer surgery. Sometimes the surgery is limited, but um, we have our radiologists are extremely committed to this, and they're very well trained in reading these MRIs for rectal cancer, as well as all the specialists that are involved in this program. This is our program. It's based out of our three sites in Long Island, Brooklyn, and in Manhattan. And as you can see, there are representatives from every discipline: medical oncology, radiation oncology, pathology, and radiology. This finally is my team. This is the colorectal surgery team. We are across all sites. So we will be very happy to see you and help you through your journey. We don't only specialize in rectal cancer. By all means, we do all sorts of benign and malignant disease. Um, but we have a rectal cancer program that we're very proud of, and it's considered a high volume program. Finally, I just wanted to touch base on how the surgery should be done. There's a lot of talk about laparoscopic and minimally invasive surgery and robotic surgery. There really was some large trials about 10 years ago that compared laparoscopic surgery to open surgery, and it didn't really show that laparoscopy is not non-inferior to open. It's a very twisted way to look at this. But, for colon cancer, it showed that minimally invasive surgery was not, it did show that there was no difference. There's no non-inferiority. But for rectal cancer, the outcomes were looking at the circumferential margin and the TME quality, and they couldn't prove that. So um, there was really then a move to do them with the robot because we feel like the robot is a better tool. And many people ask me why the robot. I think the robot has better visualization, it has better ergonomics, it's a better platform to perform the surgery. And I think it depends on the surgeon and their experience. I do most of my surgery, maybe 80% with the robot, but some of my colleagues do it open. And I think what you really want to ask your surgeon when you go see someone is what their experience is, how comfortable they are, and how many they've done before committing to them. And I don't believe strongly in one approach versus the other. Having said that, I am a believer in the robot. I think it allows me better vision, and for me personally, it's a better technique. This was really the only trial that was done here in the United States about robot versus um, um, comparing laparoscopic surgery to robot, and basically it showed that the robot potentially there was no oncologic benefit to the robot in this trial, which was relatively old now, but they showed that it's less likely to convert to open if you had the robot than if you had laparoscopy. So I think if you're gonna get a minimally invasive operation for rectal cancer, you really should find a robotic surgeon. Um, but I don't know if there's any data that shows it's better than open in any way. It is shorter recovery. it is easier on the patient to get out of the hospital. So laparoscopic approaches have some oncologic concerns. However, the robot does better overall. So with that, I thank you for joining us, and I hope I didn't over extend my stay, and I'm glad to take any questions. I'm going to stick around till the end. So thanks again.
Thank you. Hopefully you can all hear me. And thanks for those great prior talks, which really covered a lot of very comprehensive and cutting edge stuff in colorectal cancer and screening. I'm going to be brief because I want to leave time for questions. So this is really just a very large, high level overview of advances in sort of the medical treatment of colorectal cancer in 2025. So I'm going to review quickly some of the advances, again, very high level, and some of the things that are really important to us from advancements perspective are the question of de-escalating treatment, right? How can we tailor our treatment such that if someone doesn't need as aggressive therapy, either surgery, but I'm going to talk about chemotherapy, then we can give them less, but still achieve an excellent outcome. I'm talk a little bit about novel therapies and then summarize some take-home points. So first of all, one of our big questions, I would say, as we heard just now, most patients with colon cancer, and it's true about rectal cancer in terms of cure, but not in terms of surgery first, but most patients with colon cancer are able to have surgery, and that's usually the first thing we recommend. Around 70 to 75% of patients who present with colon cancer are candidates for surgery up front. Oftentimes, the surgery is enough to cure the cancer, but there are times where there are high-risk features at surgery, such as positive lymph nodes or other reasons why there is an increased risk of cancer coming back after surgery, and we would recommend giving chemotherapy to reduce that risk. Our general recommendation is to give chemotherapy for 3 to 6 months. It used to be a decade ago, or even less than a decade ago, we gave 6 months to everybody. We've now learned that many people can get an equivalent outcome with only 3 months of chemotherapy, which is very good, though not everyone. So that's one way we've sort of reduced the burden of chemotherapy. But what's really exciting and what's sort of emerging now is the use of other metrics, such as blood tests, to try to determine who's at risk of recurrence, who might not be at high risk of recurrence, and who can either have less chemotherapy or no chemotherapy and still have very good outcomes. So this is a schematic from a company that makes one of these assays. There's other ones on the market, and there are many, many in development and in discovery. And the idea behind these tests in general is looking at a person's blood to detect any sign of either tumor cells or DNA from tumor cells, something that would suggest that there is still a risk of tumor in that person. And basically what this assay does, this is called the Signatera assay that we use in clinical practice. Basically, after surgery, a piece of the tumor from surgery is taken, and a sequence or a signature of that patient is developed. And then we take a blood sample from that person, and we look for any sign in the blood of DNA that might be specific to the person's tumor. And what you can see, it's a little hard to see it, but on the right of this schematic is a person who, before surgery, had a high level of ctDNA in their blood, and that's called circulating tumor DNA. They had a tumor still present, so the DNA of that tumor was getting into the bloodstream. But then after surgery, 2 or 3 weeks later, we usually check or more, that becomes 0. And if it's undetectable after surgery, that's a very favorable sign that there's nothing residual left behind, and that person may not need chemotherapy. Now, it's not enough alone yet, but it's something that we use in combination. So this is data that was actually just presented by a colleague of mine, Jonathan Nowak from Dana-Farber, just a month ago, where they basically took samples from patients who went on a study 10 years ago, over the last decade, around 1,000 patients. And these patients were all on the study. We didn't know much else about them. And they tested from blood that was collected in the past, whether they had positive ctDNA or evidence of what's called minimal residual disease immediately after surgery. And what they basically found is that those in this graph who are in the black color, which are ctDNA negative, when you look out 5 years, over 80% of them were tumor-free and alive without recurrence, where those who were positive, unfortunately, had a much higher rate of almost 80% had tumor came back, or 75% of them had tumor come back. And so this is really intriguing data. It's real-world data, and we are hopeful that this data will help us prioritize who needs chemotherapy and who doesn't. And there are ongoing clinical trials using this kind of test, actually using this exact test and other similar tests to try to avoid chemotherapy. I don't think we'll have results this year, but we will have results hopefully over the next couple of years and be able to tailor our chemotherapy more specifically for the appropriate patients. One of the questions in this slide is totally redundant now because I didn't know about Dr. Safar's slides, but when can we avoid surgery, right? I just spoke about avoiding chemotherapy. As Dr. Safar went through in great detail, for most patients with rectal cancer, we recommend initial treatment with chemotherapy and radiation therapy, and then consideration of surgery. As Dr. Safar said, many patients, 40 or 50% of patients who get chemotherapy and radiation therapy will have a complete response where we can't find the tumor anymore. Many of those can avoid surgery, though they do need, as was emphasized, very close monitoring. So, there are studies that we're part of, that are looking at whether increasing the dose of chemo can increase the number of people who can avoid surgery. And we hope those, results will be out in the next year or two. But we do know that a large number of patients can get a complete response. If they're watched very closely, they may not need to go to surgery and can avoid, some of the downsides of having had that kind of surgery. And this is also a very exciting slide we show. It's already now data that's 2 years old, which is that some patients with rectal cancer, it's a small number of patients, probably 5% or so, maybe 10%, but probably less, have a specific mutation in their tumor called mismatch repair deficiency. And in those patients, instead of giving chemotherapy, if we give something called immunotherapy, they have a very high rate of having a complete response. In this study, it was 100%. Other studies have shown maybe 80% or 90%, but very high rates. And many of these people, if not almost all of them, can avoid surgery. And so, of course, we always now test for this marker in patients, and it will change how we treat rectal cancer patients if they have this specific mutation. This is sort of a much broader question of what's coming down the road, which is the question about whether immunotherapy prior to surgery can not only work for patients with mismatch repair deficiency, but can it help patients who are in the regular category, mismatch repair proficient tumors? And this was a presentation from a study that was done in Europe and presented but published just last year, where 100 patients were evaluated. In those in the red who had deficiency in mismatch repair, almost all of them had reduction of close to 100% of their tumor. The numbers, as you see here, around 80%. In those who were proficient, the rate was much lower, but it was still in the 15 to 30% range of patients who had a very significant, if not complete, pathologic response. And so this suggests us that some people, we don't know yet who they are, can really get tremendous benefit with immunotherapy, and we are now designing and participating in trials that are planned to test this in a much broader sense, really for everyone with colon cancer. It's still, highly experimental, but hopefully will have an impact going forward. Next, I think I only have one or two more slides. So this is what's near and dear to my heart. I run our clinical trial program and our clinical trial portfolio in GI cancers. Clinical trials are the way in which we develop new and improved therapies for patients, not just therapies, but surgical techniques, as we saw, radiation techniques. And we are looking and we are participating in some very large trials that we think will change the way we treat patients. So some of these are large phase 3 trials looking at new treatments. We're part of we led the phase 1, and we're part of the phase 3 trial of a drug called an EGFR MET by co-specific antibody, which is useful for many patients with wild-type KRAS in their tumor. We're testing that in phase 3. As I mentioned, we're looking at a trial increasing intensity of chemotherapy in rectal cancer. We're doing several trials with what are called bispecific antibodies, which target two things, or what are called antibody-drug conjugates, where you add a chemotherapy to your antibody. So these are novel treatments that are coming down the road. And of course, there are all kinds of more advanced therapies like something called CAR T cells, which is a very experimental, so early phase trial looking at giving patients novel immunotherapies to fight their cancer. These are very early stages. We do have these trials open and are conducting them. Of course, we are waiting for results before we can know whether they'll change practice. And then what I would say is, I think it's most exciting. I apologize if someone has a more exciting target, but there are a whole new class of drugs called KRAS targeted agents. KRAS is a mutation that occurs in around 40% of patients with colorectal cancer. So it's very common. You know, 100,000 people probably a year who are diagnosed with colon cancer have a KRAS mutation, maybe 70,000. And there's a whole new class of drugs that can provide benefit. We have 3 or 4 trials open looking at different drugs for different targets within KRAS. They're still all experimental, but our goal is to make sure every patient gets tested for mutations, everyone has access to the best therapy, and that everyone gets treated, you know, based on their specific tumor for exactly what they need. So that's our goal. We're doing trials to get us closer to that goal. And finally, so just to summarize what I just did in less 10 minutes, you know, the good news is that the majority of patients with colon cancer will have surgery and most will be cured. If we can prevent the colon cancer, that's even better. And of course, we are constantly trying to figure out, how we can detect this earlier if we need to detect it, and how we can improve on the chemotherapy in order to make it tailored for the individual patient. Sometimes we can cure colorectal cancer, especially rectal cancer, without surgery. And there are very exciting new therapies coming down the road. We hope that you'll hear good news and they'll be relevant for our patients going forward. With that, thank you very much. I think the last slide says questions. Perfect. It has my email. Happy for people to reach out to me, but I do think we have some time for some of the questions.
You know, it depends. You know, you have to just find someone who, an experienced gastroenterologist, and they can get through most colons. If you've been told for sure that your colon is so tortuous that they haven't been able to get through it before, then maybe a CT colonography or any of the new, methods of screening, such as the DNA or RNA, based methods. But I think colonoscopy is also good. The problem with it is you cannot get to tissue and you cannot really prove things. So when it finds abnormalities, you're kind of stuck. And if you can't get to it with a real colonoscopy, then you might end up with surgery. I don't think it's real right now in our endoscopy center, or one of our endoscopy centers. They're using AI in their algorithm for scoping. So when you pull the scope back, they have a program that sort of picks up polyps, and it sort of just starts giving you different colors and say, yeah, there's a polyp you're missing through, you're passing through, passing by. And obviously if it's a large mass, it very much alerts you. So that's the extent of it at this point. I'm sure there's a lot more excitement coming through, and there's not as much to request. I don't know what Paul has from an oncologic standpoint.
Yeah, no, I agree with that answer. I think these are things that we're just learning more about, and I think there's a lot of new information coming out, but it's not quite ready to be utilized.
IBD has connection to colon cancer, especially the length of time that the patient has had inflammation, active inflammation, and then recurrent bouts of active inflammation. We do think maybe we overestimated the risks historically, so less and less patients are coming through with ulcerative colitis and cancers, but still it's a real risk, especially if you've had ulcerative colitis for a long time. IBS, I am not aware of any connection. Thank you for that question. Actually, this I'm going to have Dr. Oberstein comment on the chemo aspect of it, but I will comment on the rectal cancer aspect. So in the pelvis, the uterus, the rectum, the bladder all live in the same neighborhood. And when you get radiation to try and reduce the rectal cancer recurrence rate, you impact fertility significantly. And you might actually send a woman into menopause, and men potentially reduce the fertility. So for women specifically, we have a good, excellent program, anywhere from suspending the ovaries away from the radiation field to preserve or delay menopause, to There's a new program. We haven't had too many patients, but whereby we disconnect the cervix from the uterus, prevent the uterus from being radiated, and then a patient can get pregnant in the future. So these are some, and again, we're forming a group, and we have actually a group. We're just sort of formalizing it where we do focusing on young adults who are developing cancers, and this is very much a focus for us. Fertility in that age group, obviously, it's young adults is defined as younger than 50.
I would just add, I know the question was regarding surgery, and I'm not the surgeon, but obviously, fertility is an incredibly important thing and incredibly important to think about it up front. So before we do anything, before we do the surgery or radiation, if that's the case, or chemotherapy, discuss the options and the implication. Like Dr. Safar was saying, we have a lot of tools to improve a person's ability to preserve fertility despite all the treatment, but it has to be discussed in the beginning to optimize that.
I agree, and those tools are in place. It's not sort of theoretical. If you were to, to reach out, we definitely have it going on.
Yeah, so I can cover that. That's what I mentioned KRAS trials. These trials are very exciting, which is why I mentioned them. They are also early. We have 4 or 5 open, maybe more, KRAS trials. The reality, though, is that each one is particular for a certain mutation or a certain patient, and so it's not one size fits all. We have a very robust clinical trial website. I think if you just Google clinical trials at Perlmutter Cancer Center, you'll come up with that website, and if you reach out to them, they can send you to the right team who can, give information about particular clinical trials. But there are, many, many clinical trials open, and anyone who's interested, reach out and we'll be happy to evaluate.